Today, we're honored to have Dr. David Sun from the Norton Neurosciences with us. He's going to do a little bit of a laser ablation case presentation on a few examples he's had over history treating epilepsy with LITT in his practice. And he's had a LITT neuroblade system for several years now. And has been a really active participant in our Lantern registry as well, which is a prospective registry tracking data and outcomes in laser ablation. And so I think has some really good thoughts and experiences to share. But as I mentioned, as people jumped on, we're hoping to create a little bit of a dialogue here. I think the best sessions are the ones where we've got some good engagement and question. And I know Dr. Sun is very willing and able to let people interrupt and comment, ask questions. That's really what we're trying to foster here. So feel free, if you have them, you can turn your camera on, unmute yourself, and go and feel right ahead to jump right in with the question. And I'm sure Dr. Sun will be happy to kind of have that bit of a conversation. So with that, Dr. Sun, I'll turn it over to you.
Yeah, my name's David Sun. I'm a neurosurgeon. I do primarily brain tumor and epilepsy work. I've been using laser ablation since, I want to say 2016 is when we installed our device, and you know, it's been a growing practice and a growing experience ever since then. I've got some bread and butter cases to present. I've got some interesting complicated cases to present. Happy to make it a discussion. I listen to myself talk all day long. I'm perfectly happy to shut up and listen to questions or debate things or et cetera, et cetera. Don't get into advanced disclosures. Okay, so, you know, all of us know that we can sort of get locked down into an hour-and-a-half long debate on a patient and what's going on. But of course, since I know the outcomes of all these cases, I've sort of, you know, cut to the chase a little bit. But we know it's much more complicated to get to the end on all these cases. But just to start off, so this is a, you know, classic sort of right mesial temporal epilepsy patient. This is a 33-year-old right-handed male, had been seizing pretty much all of his life, had different windows of time where his seizures were controlled and not controlled again. He has complex partial seizures that are controlled pretty well with medicine, but he still has simple partial seizures that are intractable. They happen daily. He did have an aura, you know, with some gastric sensations, some feeling flushed, some sense of fear. And his, you know, I don't have any EEGs on here. I don't think a neurosurgeon like myself, even though I think I can read them, my neurologist would tell me I can't. So I don't have any EEGs on the screen for you guys to look at. But in summary, you know, he'd had ictal EEG that was coming off his right temporal, and then he had a lot of interictals that were bitemporal. His MRI did show MTS, as you can see on these pictures. His neuropsych wasn't really helpful. He had undergone a WADA that had left-sided language and bilateral memory, but left stronger than right. So, you know, our concerns, you know, as the neurosurgeon, I'm like, hey, he's got MTS, you know, this is straightforward, but it never is straightforward. And the one thing I feel like I've learned is that I feel like we know less today than we thought we did 10 years ago in terms of where seizure onsets are coming from, given what we've learned about semiology and these things. So with this gentleman, we were concerned about what was going on bilaterally. We were also concerned about his insula, just because of some of the sensations that he was feeling. And so he underwent a stereo EEG. I'll be the first to say that our group is pretty stereo EEG heavy. You know, he had bitemporal coverage of the temporal lobes as well as the insula. And you can see on the top pictures here an axial and a coronal with an overlay of what the EEG contacts looked like over his MRI scan. His onset, of course, you know, common things being common, was in the right hippocampal head, as well as in the entorhinal cortex electrodes. So he was offered, we offered him laser ablation. We offered him an open craniotomy. He was very interested in the minimally invasive aspects of the surgery. He also very much was of the mindset of, well, if we do the minimally invasive approach and it doesn't work, you can always go back and do a craniotomy on me. A comment about that, it's not really, maybe it's not pertinent to this group, but I'm going to say it anyway, and I would love to hear what people's thoughts are. So as an epilepsy surgeon, I take the mindset of everything I'm doing is what's obviously what I think is best for the patient, but it's in the context of my neurologists. And so I have 3 full-time epileptologists, and I know that they want one thing and one thing only, which is seizure freedom. And so the idea of, hey, if I do this surgery, it might work, and if it doesn't, we can come back and do another surgery to get you seizure free. There's pros and cons to that, right? I mean, a lot of epileptologists will come to the table and say, I don't want you to do the surgery that you think might work if there's a surgery that you think is definitely going to work. And certainly when I started, the idea of laser ablation for a selective amygdala hippocampectomy via laser ablation, the numbers weren't quite as good as they were for an open case. I think they're getting better now. I think we've got papers now that are suggesting that they are approaching and are more on par. But I think if you're building an epilepsy surgery program and you're trying to bring laser ablation in, maybe not pertinent to this group because we have a lot of experienced users, but I think you have to keep that in mind where your neurology team is coming from. In this case, I'm lucky my neurology team is very excited about innovating. They're excited about minimally invasive approaches and things like that. So we did a selective amygdala hippocampectomy. You can see this overlay of our SEEG and the post-op flare images on post-op day 1. He was the first one I did actually, and he has been, knock on wood, seizure free for over 4 years now. In terms of little things about the surgical technique, this is more of a neurologist heavy group, which is fantastic, but there are things you have to take into consideration with your targeting. When you take this sort of oblique angle to the skull, there's a tendency for the drill to want to skive. And when it's skived, if you see that arrow, that's the trajectory that I want. And because it's a little oblique to the bone and less orthogonal to the skull, it has a tendency to be able to skive. And if it skives, it's going to lead you to be a little lateral. When I do my procedures, I drill a pilot hole. That's just the way I like to do it. I drill a pilot hole with this triple fluted drill bit, which is really great. Before I used it, I had skiving problems a lot. After I started using it, I really saw a lot of my skiving problems go away, and so I tell everybody about it now. I learned about it at one of the Monteris meetings. Apparently, I was the only one that didn't know about this drill bit. So as soon as I got this drill bit, it was great. But something to think about there. So this is just sort of a bread and butter mesial temporal case. He did wonderfully. Knock on wood, he continues to do wonderfully now. In contrast, here's you could repeat the story. All right, so here's another right mesial temporal case. 33-year-old female, been seizing for about 5 years. She had an SEEG as well, covering the right temporal lobe and the insula, and her onset was in the right hippocampus. She did not have MTS on her MRI scan, so she had a non-lesional MRI scan, and she underwent a SEEG. Now here's the thing. So this top image here, I hope you can see this. This is an overlay of my trajectory, and this is what the burn looked like on post-op day 1. And immediately you can see it looks a little lateral, She unfortunately kept seizing. She had significant reduction in her seizures, but she was still having about a seizure a week, and this was about a year and a half after her surgery. This bottom image, the axial and coronal here, this is her 1 year post MRI scan. And you can see where the ablation is, and you can see that there's a ton of hippocampus left here. So, this to me is an abject failure. And so we had to sort of decide, what do we want to do? We told her that we could go back and redo the laser ablation, or it would also be very reasonable to go back and do a craniotomy. We sort of left the decision to her. And I showed her the pictures. I said, I didn't get everything I wanted to get. So we repeated the surgery. And this time, simply because I had already done it via the other approach, I used an orthogonal approach, sort of a transtemporal approach rather than an occipital temporal approach. And if you look at these MRI scans, what I've tried to show you is the red. I hope it's projecting well. It's not projecting great on my own screen, but the red is essentially the lesion that we created with the first procedure. It's a little lateral, it's a little posterior. The second procedure, using that orthogonal approach, you can see in orange, it's much more medial, it's much more anterior. And as of the second surgery, she has been completely seizure-free up until, well, post-op. She's seizure-free going on about 10 months now. This is a classic targeting problem, and I don't know if it was because I skived with my drill bit or if it was because I targeted a little lateral, but it's clearly off. There is a nice paper that came out. I put the reference there in Epilepsy in 2019, where they took a bunch of patients and they basically contoured all of the laser ablations and just gave sort of predictive values. And what they showed is exactly what this case shows, which is that if you concentrate on getting anterior, getting medial, and getting inferior, you will get the amygdala, the hippocampus, the entorhinal cortex, the perihippocampus, and that had positive predictive value. In contrast, if you got more of the posterior lateral superior hippocampus, that had negative predictive value. I don't think that negative predictive value means that it is bad to burn that. It just means that your trajectory is going to have a consequence. If you're focusing on getting that, you're not going to get the medial anterior stuff. I don't know if anybody else has had any experience like this where they just didn't get the burn that they wanted to get. But if you look at these pictures I'm showing you and you go to that article, you're going to see that my failure, the red contour that failed and the orange contour that succeeded, they lay down exactly on top of that paper in terms of the predictive value. So there was a lesson to be learned there. I think a lot of guys will tell you to target sort of one third. If you're looking at the hippocampus, they say, target to the medial 1/3 is what I hear a lot of folks say. But this is really what you're shooting for. It's not about getting more of the length of the hippocampus. It's really getting the hippocampal head, the entorhinal cortex, the amygdala, and pushing all the way up. I push now all the way up into the uncus when I'm doing my amygdala hippocampectomy cases now. Anyone have any comments or thoughts about those two mesial temporal cases?
Do you, I may have missed this, but what do you use for your stereotaxy? And have you had experience using different things? What are pros and cons to different methods?
Yeah, so can you jump to my workflow slide at the very end? I'll just sort of review. This is what I have. So I have BrainLab, I have an intraoperative CT scanner, and I have a ROSA robot. I do not have an intraoperative MRI scan. And so what I do is I get a CTA and I get an MRI scan to do my trajectory planning. I use that for my SEEG as well as for my laser ablation. And one of the things that I have learned is so I use what I end up doing is I end up doing my planning on BrainLab because it's very hard. I don't know how many people have ROSA. ROSA's great. You can put you can do an SEEG with 20 electrodes, and you can, it's 90 seconds per electrode at this point for me to put them in. It's also great because since I have that, I'm not afraid to do multiple trajectory laser cases because it's just so easy to put the bolts in. One of the things that I've started to do, which has been really helpful for me, is so I use BrainLab and then I get that data transferred over to the robot. But in BrainLab, I can draw structures, I can draw objects, and I do these burn-ins, especially if I'm doing like 2 trajectories, where I will burn in the trajectories on an MRI scan, and we'll use that in the OR, down in the MRI scanner. so one of the cool things about doing that, I mean, is, especially if you're trying to burn something that's a little funny shaped and you're using multiple trajectories and you're not sure what you're going to get, by putting that burned in of the second trajectory, what happens is, so you're burning on the first trajectory and you're getting everything you can get. But because you can see your other trajectory burned in, you can get to a point where you can say, all right, I'm at a diminishing return point on what I'm getting off the first trajectory. Let's jump over to the second one, because you can see it. You can see it in real time. And I do that with eloquent cortex. If I'm going to be close to Broca, I'll map out Broca, burn it in ahead of time. So I do all of that stuff. And then I use the Automa system because I don't have an intraoperative MRI. So the patient's in the OR on the Monteris board and the Monteris head holder. I really like the Monteris head holder because it's got so many options. I do use bone fiducials now. With ROSA, you can do a face registration, which works really well. But the truth is, it's more accurate with the bone fiducials, and it's actually faster. Once you get good at it, it's actually faster. As I mentioned earlier, I always drill a pilot hole, whether I'm doing a biopsy or not. I always drill a pilot hole. I just think it helps me not skive as much.
Do you have experience using the VarioGuide for in the BrainLab system?
Yeah, so I use VarioGuide for biopsies all the time. And what I used to do biopsies the way we're all trained to do biopsy. You make a 2-centimeter incision, you drill a burr hole, you bring the VarioGuide in. Once I started doing stereo EEG and laser and started using this, orthopedic hand drill, which I'd never used in residency, I started doing my biopsies with VarioGuide in the OR, where now my stereotactic biopsies have this 2-millimeter incision, because I'm just drilling through the VarioGuide as if I was doing a laser and SEEG, and it works great. It's not designed for that, so it's not technically approved for that, and it will. I find that a VarioGuide arm will flex a little bit. If I didn't have a ROSA, that's what I would be doing. So you
don't think it's good enough for this oblique?
I think it is. So what I do is I use my other hand as a counter traction on the VarioGuide, so I feel like it's not flexing as much. But if I didn't have ROSA, I would use it.
Gotcha.
It never going to be as good? So the end all be all with laser ablation is, it's all about where you get the damn laser. If it's not where you want it, you're hosed. And one of the things that I do in the OR, because I have an Aero scanner. So I don't have intraoperative MRI, but I have an intraoperative CT. So after I place my bolt, after I place my anchor bolt, I get an and I'm ready to go downstairs to the MRI scanner. I get an intraoperative CT, and I look at the trajectory that the true trajectory that the anchor is going to put the laser. Because what I think is, if I'm off target, it's easier now to add a target and place another bolt than it is to get downstairs, get to the MRI scanner, see that I'm in a bad position, have to come back upstairs. So I add that extra 6 minutes to my process to know when I go downstairs that I know exactly where the bolt is going, where the bolt should take the laser, if that makes sense.
Yeah.
So this is my workflow. I'm sure it's very similar to everybody else's, but this is what I do. These little tweaks, these little innovations for me of like burning in the extra trajectory has really been eye-opening. It's how productive that is, because when you're down there, you're not guessing what the other trajectory is going to do. You can actually predict, based on this burn-in, this is what it's going to do. And I find that to be helpful. I've been telling people a lot about that lately.
Because you don't have an IMRI, so what we're doing is at KU is we use ClearPoint. And I would use ROSA for a case where I have multiple trajectories. So example, corpus callosotomy, I'm trying to do by laser, that would be multiple trajectories. But I can tell you that maybe I just haven't perfected that well enough. I did use bone fiducials, but I didn't feel that I got the accuracy, the desired accuracy with the bolt placement. And I was doing something similar to you, meaning like we had an Aero CT scanner and then scanned it and then went back in. But if it's a mesial temporal case, I'd use ClearPoint, because I feel like I get the best accuracy. But I guess looking at that case you were showing as your second case, do you find that you're doing single trajectory for a typical mesial temporal ablation these days, or more likely 2 trajectories?
It's always been one. So it's always been one trajectory. This was just an example of a trajectory gone bad. The laser wasn't in the right place. You know, it wasn't medial enough. And what I did was I came back. I made the decision when I came back of, well, I don't want to replicate the same mistake I just made. So I'm going to come from this, you know, orthogonal approach because I know exactly what I missed. But I always do one, and that's the key, right? I mean, we all know the hippocampus is like a C shape, right? It curves around. And so you have to either decide you're going to focus on this trajectory or focus on this trajectory. And my experience, and I think that what the literature is starting to show us, is focus on that anterior medial. So now what happens is my trajectory on the skull, I have a skull, you know, I don't know if you can see it, my trajectory on the skull has gone from less of a posterior to anterior and more of a lateral to medial, which helps me. The skiving's better because I'm a little more orthogonal on the bone, and I haven't had a placement problem since I started doing that. Yeah, I mean, everybody's got a different device, right? But like you said, ultimately it comes down to what you think is best for you to get it where you want it. I will say one thing I started doing on the ROSA recently, because you said you do have a ROSA, is, you know, when the ROSA arm moves from home position to your trajectory, I used to always have the instrument holder in the ROSA, you know, the little bushing.
Yeah.
And I started to take it out when it moves, because we looked at it and we realized one day, it's like, you know, when we register the ROSA, that extra 30 grams of weight of however much that bushing isn't on there. And so we sort of asked ourselves, I wonder if we would be more accurate if we took it out when the thing is moving to position and then put it in. And I can't prove it to you, but I promise you the device is more accurate if you take that bushing out when you let the arm move from home to its trajectory. My SEEG accuracy has increased by about 2 millimeters across the board, you know. So just an anecdotal point about ROSA. I know a lot of people have it, a lot of people don't. Because I don't have an intraoperative MRI, you know, we use the devices we have, right? So I do one trajectory on those hippocampus cases.
Okay, that's a good. I'm going to try that with the ROSA arm, because it can be quite variable in terms of where you get accuracy issues. I don't know if there's no rhyme or reason to how or why.
Yeah, I mean, I think the way the head is fixated obviously matters. You know, you always got to push on the head and see if there's the rotational flex. I think that matters. I do think that the bone fiducial registrations are better. And you know, I actually think they're faster, you know, now that I've done it a number of times. And moving that anchor thing has made a huge difference. The other thing, like I said, is that triple fluted drill bit that I never used before, I also think makes a difference.
Okay, I'll have to talk to my reps and look into that. So I was just going to say that my recent medial temporal ablations I've done with LITT, we also use Monteris at KU. So I've been doing multiple trajectories for each one, and the reason being that at the widest point I find with the Monteris laser is giving me like a 15 millimeter distance across diameter burn. And so if I want to try to get as much of the amygdala as possible, which is usually that large structure there, it's more effective for me to create both a medial and lateral trajectory that come through the same entry point. But that's because it's clear point. You're not dropping a bolt in the OR, and you can do some modification on the table. And
right.
So
yeah.
that's
You have that flexibility. Yeah.
Right.
What laser tip do you use?
So
what probe do you use?
The full fire. I used to use the smaller diameter one. But now I'm using the larger diameter full fire. I haven't been using the side fire much because I'm not using the robot. I just use ClearPoint, and then I just manually move the laser in and out. But that's what I've been doing.
So I use side fire. It's got pros and cons. It's slower, but it actually, at the highest power setting, it can actually make a larger lesion than the diffuse tip. I don't use the smaller probe. You know, I asked early on the Lantern folks, you know, I said, you know, can you look at the hemorrhages that we've seen and, you know, send me the number of hemorrhages we've seen and what probe tips were being used. And it didn't look like there was a difference in the hemorrhage rate between the 3.3 and the 2.2. And so unless I have a super tiny lesion, I don't use the 2.2. I use the 3.3 for pretty much all cases. I like it because, one, if I'm using the diffuse tip and all of a sudden I get into a jam where I'm like, uh-oh, I need a oblique thing, it's easy just to switch it because I'm using the anchor bolt. But I do like to use the side fire because it allows me to, you know, push that heat as far medial as I can, and then rotate it and push it, and so I do get these directional burns that I do. I like them that way, but it's slower, you know.
Yeah, I think I will reinvestigate using the side fire. I think that in regards to safety, well, I am using ClearPoint. So there's a ceramic stylet that I use the blunt ceramic stylet tip that goes to the mesial temporal lobe. And, you know, I can, you know, my tolerance for how close it is to surface vessels is a lot different. And because that drill will be near there compared to how it passes by under the ventricle near vessels. And if that ceramic tip can get to the target, then the I used to be worried about using the larger diameter laser as well, but it'll follow the track of the ceramic.
I also make a track. That's another thing that I do that I don't think I actually put in my workflow, which is once I put the anchor in, I will use whatever that spear-looking devices that they have, and I will also make a track. I don't take the track all the way to target, but I'll get it pretty darn close to target. The only reason I don't take it all the way to target is because I don't want the artifact on the MRI scanner where I've got more dropout than I had to have. But I do make a track about 80% of the way there. Oh yeah, so word of caution. Okay. I don't know if anybody's seen this. I've seen it once. The basilar cisterns and the vessels along the basilar cisterns should act as a heat sink. We all see them act as a heat sink, and they act as a great heat sink, except when they don't act like a heat sink. And I had this happen one time where, you know, so if you look at these pictures, the first column, what is the order here? It's pre-op, post-op day one, and the flare images on the top there. And what you can see is that's the burn that I got. But if you look right here, I hope you guys can see that, there's injury there in the midbrain. And that's exactly how my patient woke up, with, you know, a hemiparesis because of that injury. And it was real. Post-op 4 months, you can sort of see on this flare, this is actually Wallerian degeneration, I bet. You know, you can sort of see this here. It's a real thing. It's not supposed to happen. Those are supposed to be heat sinks. With the software that we have with Monteris now, you can monitor multiple points, monitor the temperatures on multiple points. And I now, I didn't have that back then on this case, but I now put points along the midbrain. And as soon as I get any heat there, I basically just stop, let everything cool off, and then start again. And then I stop and let it cool off and start again. And it adds a little bit of time to the case, which is frustrating. But, you know, this case really stunk. This patient's seizure free, but she still has got, you know, she has permanent weakness. So just a word of caution, you know, it's not supposed to happen, but it can absolutely happen. Has anybody else seen that? I'll take silence as a no. Yeah, so apparently it's just me. Let's move on.
No, but there has been, as you know, injury like creating homonymous hemianopia via heating of the lateral geniculate, and that has been reported to happen, especially after like on a redo laser where the choroid and is a little bit probably a little burned after the first procedure. So definitely can happen.
Yeah, it can happen. And you know, I don't have the heat maps on that patient, but they were really weird. Like it was a discontinuous yellow line that just popped up over there, and we honestly didn't think it was real. We thought it was artifactual at first, and eventually, you know, and then we said, well, who knows? But it can happen. So, all right, let's see. Moving on. So this case is a 19-year-old right-handed male. He's been having seizures for 4 years. He has complex partial seizures. His EEG is all consistent with a right temporal lobe onset. He's got this MRI scan T1 on the top, T2 on the bottom. You can see this cystic lesion with a small area of enhancement here. His neuropsych was consistent with some non-dominant dysfunction, but no mesial temporal dysfunction. He's in college. He's an engineering student, and he's an active wrestler. Okay, so he's on the wrestling team. He's having these seizures. He's still allowed to be on the wrestling team, which I think is great. But this is sort of where we are. And so this is somebody that I think, you know, in a heartbeat, I would have said, do a craniotomy. You know, it's a lesion on the surface. It all makes sense. But the flip side was, hey, I've got minimally invasive techniques that I didn't have before. And, you know, I approached him and said, we can do it one of two ways. We can do a craniotomy, or we can do it minimally invasive. I think we can get the job done. We'll do a biopsy during the procedure. He's very interested in that purely from the minimally invasive perspective. You know, he was concerned that if he had a craniotomy, that the college wouldn't let him wrestle anymore, things like that. You know, we have to take those kinds of things into consideration. So I lasered this. I did a biopsy. It came back as a ganglioma. This is a pretty straightforward case, I think. Couple of points that I think are important on this case from a surgical perspective, less so from a epilepsy perspective. But this is a very thin bone. You know, this low temporal bone we all know is very thin. And if you have to screw in an anchor bolt, you really need to, you know, you got to get it right. You got to get good purchase. Another issue, I didn't know what kind of tumor it was. And so I'm going to do a biopsy. And when you do a biopsy, you are going to, you know, you need to get good tissue. You need to get good samples for your neuropathologist. But at the same time, that's going to cause artifact. It's going to cause a lot of artifact on your thermal scans where you're going to have dropout. So here you got two reasons to have dropout, right? One, you're along the edge. So it's the challenge. You need your anchor bolt to be in that thin bone deep enough that you've got good purchase. Don't ever sacrifice good purchase, because then your laser's not going to be where it needs to be. But that anchor bolt being so close to the lesion is going to cause artifact. The biopsy sample is going to cause artifact. So this is one of those cases where I'm very glad that I bring in that MRI scan where I've sort of drawn the object ahead of time. Cover your ears, guys. I don't like the Monteris drawing software. So I do it in BrainLab, and I bring that scan in and I fuse that scan on top so I can target off of that scan. I think that helps some. But those are things you really have to consider. You know, your pathologist wants as much tissue on their biopsy as they can get. You probably don't want to give as much tissue because you're going to cause dropout. But he did very well. He's been seizure-free. Here's just a couple points. I already just said this, but you know, with surface lesions, the anchor bolt's going to cause artifact. I try to place it more shallow when I can, but when the bone is thin, you don't have a choice. And what I do is I draw the object so that I have another image to look at that I can go back and forth on. Pretty straightforward. I think a lot of people would say just do a craniotomy on that. I love the idea of being minimally invasive whenever we can, and as a wrestler, this was a great case for that. Any questions or comments on that one?
Okay, can you go back to the final lesioning?
Yeah, so I have the only pictures I actually have for you there is the 1 year post-op on that bottom. For some reason, I didn't put the post-op. I always get a post-op day 1 MRI. It's just what I do. For some reason, I didn't put that on there. I apologize. I just have the 1 year post-op.
And what do you think is this area of contrast is what?
I don't know, to be honest with you. It is over where we burned the tumor. I've looked at that before, and I've gotten multiple scans on them, and it hasn't changed. So I'm waiting. I've expected it to die away. I don't think it's viable tumor. But yeah, it's this little area here. That's why I put the scan up there. This little area here and here, you know, it's right over the blue line ablation. I should have put that on there. But it's right over the blue line ablation. And it hasn't changed. Now, granted, it's a ganglioma grade 1, so if it's going to change, it may be God knows how long, if it's ever going to change. But it's a great question that I don't know the answer to. You know, I would have expected that to become sort of a cystic cavity by now.
Right, but this is not something that I saw in your previous cases.
Right.
So
Exactly.
therefore, if you had a tumor there, that raises a question about subtotal, lesioning, right?
Correct. Which, yeah.
So I mean, I appreciate, the discussion, but I'm looking for the indication. So in a developmental tumor, and that could change over time, of course you're right, it's very unusual.
Yeah.
But which also surrounded by focal cortical dysplasia, just removing a part of the tumor, in epilepsy surgery is a critical question. So I don't know that, I mean, it's a debate, right, depending on how each case does, but I don't know that laser is the way to approach, just look at the tumor and remove it. Otherwise, we don't need EEG, we don't need anything else, right? Usually the tumor itself is glioneuronal, so you don't have the inside of the tumor producing the epilepsy, it's the surroundings of it. So I would be cautious, with suggesting laser in this case, at least based on my understanding of this epilepsy.
Yeah, so I have another case that I'm going to show that really I think hits home to exactly what you're referencing. And I think that's so philosophically, one of the things that I feel like is happening both with stereotactic EEG and with laser ablation is so for me, when I trained without either technique, I did not learn stereo EEG in my residency or fellowship. I learned it sort of on my own out in practice. But one of the things that I feel like is a very natural trend, which I don't think is correct, is the idea of less is more. Okay, especially when it comes to epilepsy, because usually our onset zone is larger than what we're actually seeing, especially now on stereo EEG, right, where we get these pinpoint data sets. And to your point, I think that we have to be really careful that we're not saying, oh, I can make this tiny little lesion and that's going to solve all the problem. And I've got a case where I will try to prove that to you. I will say, I do take your point. I've done this a couple of times now on these low-grade developmental lesions, and is that mine? Is that me?
Oh, it was mine. I'm sorry. Yeah.
No, it's no worries. But it's actually gone quite well. But I do 100% get your perspective. I've done a couple of cavernous malformations. I was trained in the world that with a cavernous malformation, you need to resect the cav mal and you need to resect the hemosiderin stained brain around the cav mal, because the cav mal is not neuronal. It's not inducing, it's not causing the seizure. It's the brain tissue around it. And I've done a couple of cav mals, one of which was very unsatisfying with the laser. I did it because it was so deep seated, but I could not get a quality ablation far enough around it to actually do what I needed to do. In contrast, I had another one where I did a cav mal. I don't have the cav mal slides up, where I did the cav mal, but the intent was to ablate a margin around the cav mal. And that case so far has done wonderfully. But to your point, whether it's a neuronal tumor or a cortical dysplasia or even a non-lesional thing, I think we have to be careful about the idea that less is more. It's always really been that the resection, more of the resection is going to be better, in my opinion, in terms of surgical outcomes for the epilepsy. So I absolutely understand what your point.
I mean, I would tell this patient that this is unlikely to remove the epileptogenic area because we know that the dysplasia is by definition surrounding what you see on the MRI. And these tend to be more difficult than we think, because it's is not visible, you know, the extent.
Right.
They are difficult sometimes to manage, and
yeah.
you,
Although I do think,
can
I mean, when I've
really-
resected gangliogliomas for epilepsy in the past, you know, in contrast to a cav mal, I haven't taken a margin, and I think we've had very good outcomes in contrast to a cortical dysplasia. In fact, why don't we jump to the cortical dysplasia case that I wanted to show you. Let's skip this one and go to the next one. What I believe now is exactly your point. So this patient is a 38-year-old left-handed male. He's been seizing pretty much all of his life. He has nocturnal generalized tonic-clonic seizures. He's had EEG, MRI. He's had every test he's supposed to have. His seizures appear to be coming from the left side. And this is his preoperative MRI scan. I've tried to outline for you this very subtle lesion thought to be, you know, a cortical dysplasia here and here. I hope you guys can see that. He is a vagus nerve stimulator. So he underwent a stereo EEG. And I don't have the actual overlay of the contacts, but I have an overlay of the seizure onset zone. So this is what his SEEG showed. These orange spots on my pictures here are where the SEEG trajectory said that he was having onset. And so we made the decision to do a laser ablation. Again, the only real reason to do a laser ablation versus an open craniotomy on this case is simply because it's minimally invasive. That's the only reason. Surgical considerations, again, this is a lesion that's close to the surface, so if you're using an anchor bolt, there's going to be potential artifact. The other big thing here is he's got a vagus nerve stimulator. And if you have a vagus nerve stimulator, you have to use a transmit-receive coil. Some people call it a send-receive coil, some people call it a bird cage. If you don't use a coil like this, then what the vagus nerve stimulator people tell you is that you can only scan for 15 minutes at a time. So you can scan for 15 minutes, and then you have to stop for 15 minutes. Then you can scan for 15 minutes, you have to stop for 15 minutes. So you have to have one of these stupid looking head coils. And of course, these aren't sterile. So it's a real pain in the butt because you need to pass your probe driver and you have to pass your laser through these little slots here. I hope you can see that to do it. So when we do it, just to talk about the technique, we basically sterilely place, we figure out where we turn the patient's head. So we're going to align with one of these columns, and then we place tegaderms in between and we wrap them to kind of make it sterile. And then basically two people hold the damn thing up and you pass the probe driver through it sterilely and you put it in place, and then you pass the laser and you clamp it down. And it's a real pain in the ass for about 10 minutes, but it's very doable. I don't know if anybody else has had experience with this, but it's just something you have to know. If you've got a vagus nerve stimulator, this is a problem. I was going to do a corpus callosotomy when I first started, and I was all set up and ready to go, and I did not appreciate that if you have a VNS, that you have to have this special coil. We didn't have it at the time, and next thing you know, I had to cancel the case and do it open. So just be aware, if a patient has a vagus nerve stimulator, you can laser ablate them, but you need to have one of these coils. And I have not heard any updates that say otherwise yet. So
or you can also remove the vagal nerve stimulator, which is something I've done occasionally for LITT.
you could remove the VNS. I haven't done that because I'm afraid what if it actually helps, but yes, you can remove the VNS. So we did a single trajectory laser ablation, and this pink, so I've sort of overlaid things on top of them. So the blue is the original lesion, the orange is where my onset zones were, and this pink is what the ablation looked like. And he was seizure-free for about 4 months, and then he started seizing again with the exact same semiology. And so like an idiot, I went ahead and I did it again. Okay, I did another laser ablation, and I basically said, this is a cortical dysplasia. I didn't burn enough. I went in and I burned it again, and I got a much larger lesion. Now you can see this green line, green curve sort of demonstrates where he is now. Now he's seizure free for 8 months. And I think, okay, we've finally accomplished our goal. Then he starts seizing again. So we did another stereo EEG. You know, we were concerned maybe he's got a new onset zone that we're not aware of. We actually put some electrodes on the right side. We had left frontal coverage around the lesion. We had some right frontal coverage. He had multiple seizures, all coming from around that area. And this is getting to the conversation we just had about a dysplasia. So this purple, which I hope you can see here and here and here and here, this is outside of where that lesion on MRI was. And this is where the second SEEG was mapping his onset zone. So at this point, I realized that, you know, this was not the right way to go. And I went ahead and took him for a craniotomy, and I resected this area, and knock on wood, thus far, he's seizure free. It came back as a type 2 cortical dysplasia, you know, and this was the wrong case. This was the wrong thing to do. I know there's a literature out there of people doing cortical dysplasias with laser ablation. You know, this was the wrong one. To the comment made earlier, you know, it's a tip of the iceberg phenomenon. What we see on the MRI scan is not everything that is going on histo, you know, or neuropathologically, you know, in the brain. And, you know, this was a mistake. I deem this to be a mistake. You know, if the goal of surgery is seizure freedom and improved quality of life, it's not to have tiny, cute incisions. And I think in certain patients, that minimally invasive can push you one way or the other. In this case, I think I made the wrong decision.
Did you have the first SEEG before the laser? Like, did that have coverage like around the lesion?
Yeah, it was perilesional, but the onsets were the ones that I showed you.
Okay.
Yeah. So I'm not saying don't do it, but I'm saying, you know, I think like I said, there is a literature out there of cortical dysplasias being successfully treated with a laser. I'm not saying don't do it, but I'm just saying, you know, you got to really think about the prospects of what's really going on in the brain besides what you're simply seeing on the MRI. Now here's a periventricular heterotopia case. This is a 23-year-old. She's been seizing for about 10 years. She has 3 to 5 seizures a month. She has these auras. She has these staring spells. She's got interictal EEG with bitemporal spikes, and then her ictal EEG, she's got, you know, mostly left occipital. She's got bilateral periventricular heterotopia, as you can see on these arrows. Neuropsych, I've got a great neuropsychologist, so I do lean on the neuropsych a lot. She's got temporal dysfunction, and then she's, you know, so it's all, she's got lateral temporal dysfunction on her neuropsych. So we stereo EEG this patient. You can see some cuts here sort of showing the electrodes. And she had 8 seizures for us, all coming from the left heterotopia, but with very rapid spread to the right side. And given her interictals, you know, we were very concerned that this is a very highly networked patient. I think the laser here is a great option for these kind of lesions simply because they're deep-seated, you know, and if I can get to them with a laser, I think that there are opportunities to do a more elegant surgery. So that's what we did. We did a single trajectory ablation of the left heterotopia. My trajectory, you can kind of see here. You see, this is the heterotopia. It goes all the way here, and then there's a little bit of it right through here, you know. And I wanted to get as much as I could get. So I targeted like this, a little medial to lateral, knowing that I've got, you know, visual cortex here. That was what I did. Interestingly, you know, on post-op day 1, my ablation just looked like this on post-op day 1, which was a little strange to me. It was more of a blush than it was the sort of halo that I like to, enhancing halo that I like to see. And she went home on post-op day 1, no real complaints. On post-op day 3, she came to the ER because she was noticing some temporal vision problems. She didn't have that when she first woke up. She didn't have it when we sent her home. She got a new MRI a few days later as an outpatient, and you know, from post-op day 1 to post-op day 7, this is how the lesion evolved. So it went from this to this, and this is something that I sort of expected to see on the initial ablation based on my blue lines. I put that up there just to sort of say, hey, look, this is something that, you know, this is the normal. When you first start doing laser ablation, you really have no idea what the scans are supposed to look like. You know, and when you bring it into your hospital system, if your radiologist didn't have it where they trained, if they've been around for a while and they didn't have it, they have no idea what the scans are supposed to look like. But I know for certainty that these lesions evolve and they get larger before they get smaller. I'm waiting for us to get a textbook, a radiology book out that basically shows these sequential lesions to show people what do they look like at 1 day, 7 days, 3 months, et cetera, et cetera. Here's what it looked like a year later. So now here, this is kind of what I expect to see, right? This sort of small cavity, it's kind of collapsed. Again, look, there's a little bit of this weird enhancement there. I don't know what the hell that is, you know, but that's what I saw. She did end up with a right superior quadrant nopia, and she, it didn't bother her, but she had it, and she did well for a while. She eventually started to seize again. She was seizure free for about a year, and then she started to seize again. And at this point, we said, well, we didn't even re-SEEG her. We basically said, you know, we knew how highly networked she was. We should just go and hit the other onset zone. And I remember being at a meeting not long ago. Well, actually, it was long ago. It was pre-pandemic. And a case just like this was presented, and they didn't even do a stereo EEG. And I thought they were crazy not to do the EEG. They just hit both lesions. And I said, well, I guess that's one way to do it. We all have our ways to do it. And I presented my case. I said, well, this is what I've done, and she's done well so far. But guess what? I was wrong. So we came back and we hit this other lesion on the other side. I felt like taking a more straight-on trajectory here, because of the visual cut that I had caused by coming a little more medial to lateral. And by taking this more straight on approach, just having her prone in the OR, not coming medial to lateral, just getting what I can get. And again, this is a case where it's a small lesion. You wouldn't think to use side fire, but I basically used side fire so that I could send it one direction to get more of this lateral stuff, and then flip it the other way to get more of this medial stuff. So I'm sort of targeting, knowing that I'm going to create 2 eccentric lesions. She's been seizure free so far. She did not get a new field cut from the second version. You know, I don't know how I would do this surgery without the laser. I don't know if I would have been willing to do an open craniotomy on the first side and then do an open craniotomy on the second side to handle this. I'd be interested to hear what other people's thoughts are, or what other people's experience is.
So we did one case similar to this, although the ablations weren't as extensive in these posterior heterotopias. And unfortunately, the patient saw relatively little benefit. We did one more anterior in the frontal areas, and Dr. Cheng can certainly speak to that because she did the second one, and she's done remarkably well. She's gone from weekly convulsions to she's had 2 in the past 18 months, so better than we would have thought, to be honest.
I think what stereo EEG is helping us realize is that some of these patients are just incredibly highly networked, and we didn't know that just from a couple of depth electrodes and a bunch of grids. You know, this is I think this is what we're learning. You know, this patient was somebody that we told her this is probably palliative, and I don't know if we're going to get everything we need to get. She had interictals that were coming, you know, she had rapid spread across, she had rapid spread to her hippocampus. Yeah, I don't have a great feeling that I can tell a patient with confidence what we're going to be able to accomplish here, but she's doing well. let me go back to that case that I skipped. It's 7 o'clock, so if people need to leave, go for it. I'm happy to show this last case quickly, if I can get back to it. Where the hell was it? It was case 4. And if people all need to leave, you know, I understand. I can talk about this stuff forever, but this is the last case that I have a file for. So here's a 22-year-old right-handed male. He's been seizing for years. He has seizures once a month. He also has nocturnal seizures. He also has an EEG that suggests left occipital lesion. His MRI scan is negative. His PET maybe showed a little something. You know, I find that sometimes I have to blur my eyes and say, yeah, I think I see something there. He had a SPECT, which suggested left temporal occipital junction. So everything is sort of coming into this sort of left posterior quadrant. We stereo EEG'd him, and this is sort of an example of what we saw. So he had broad left occipital coverage, and unfortunately, he only had one of his habitual seizures, but he had 30 subclinical seizures, and there were two patterns. So we saw 2 separate onset zones. So 24 of the 30 some seizures started in one spot, rapidly spread to the other spot, and then we picked them up on another set of contacts. And then the other seizures started in onset zone 2 and spread to onset zone 1, and then seemed to go to that common, what I call a common node. And this is, again, getting to this concept of what we're learning from stereo EEG and how networked these patients are. So he's got 2 onset zones that seem to spread from one to the other back to one, and then they come to this common node before he has his semiology onset. We mapped him. We couldn't get a consistent visual field deficit. I think that's just an issue with us learning how to map with stereo EEG versus with grids. We did find a basal temporal naming area on him, and so rather than go in and basically do an occipital lobectomy, we decided to first try by targeting all 3 of those spots. So what we did was we targeted onset zone 1 with one trajectory, onset zone 2 with another trajectory, as well as that common node. And he's done beautifully. You know, he's been seizure free since the procedure. He did not have a field cut when we were finished. He still does not have a field cut. He's actually in the police. His dream was always to go to the police academy, which he couldn't because of his seizures. He's now able to, he's in the police academy now. You know, this is a case, I find this was a very satisfying case. We probably could have done a lobectomy on him and certainly given him a, you know, a significant field cut, a field cut that probably would have kept him from going to the police academy and things like that. I think things you have to consider, you know, vision, it's a multiple trajectory case. So if you don't have a system where you feel like you can do multiple trajectories or you're not comfortable with that, then obviously that's going to be a problem. I'm lucky that with Rosa, multiple trajectories are quite easy to do. But this is this case has been very satisfying to me because, you know, of how highly networked he seems to be and the fact that we were able to get a good outcome from it. So I think that was the last case I wanted to present. Any comments or thoughts on this case? That's all the cases I loaded up for you guys. I hope I've given you sort of some things to think about, some things that I think work, some things that I think don't work. I appreciate everybody taking the time to be on here, and I appreciate all the comments. If there's anything else anybody wants to talk about, please let me know.
Well, I'll personally say thank you, Dr. Sun, for the time, and thank you for everybody else for taking time out of, I know, what is busy schedules to join us. But hopefully you found this useful and helpful. That's really what we're trying to drive to, is help people share experiences. So it was a great discussion, Dr. Sun. Thank you for leading us through it, and everybody have a great, safe, and wonderful rest of your evening.